Wonderful. Thank you very much. And just another reminder that the event will be recorded in both English and Spanish, and the recordings will be shared with all participants via email after the event, and we certainly invite you to forward them to anyone else you think will be interested. My name is Jennifer Stedron. My pronouns are she, her, and I am Executive Director of Early Milestones Colorado. Early Milestones Colorado is a statewide intermediary focused on all things early childhood for families and children prenatal through age 8, and that includes an emphasis on learning and development, family support and education, and health and well-being. And we'll be talking about health and well-being today. This webinar is part of the Milestones Racial Equity Project that examines equity issues among young children in Colorado. This is part one of that work, and we're very, very excited to be launching it today. I want to introduce the leader of that work, my colleague, Freeman Cenegy. She will be presenting the data from the National Survey of Children's Health and some really interesting and findings that I hope will spur us all into action. There's a lot to do. Laura is a PhD sociologist who specializes in population health. She leads Milestones efforts to study health and well-being among young children, prenatal through age 8. And her research course examines the root causes of health inequities across the life course. We also have two amazing panelists that will be responding to the data and information presented, and then jump-starting us on what I think will be some really juicy and interesting question and answer period. So I'd love to introduce those two panelists. First, Annie Lee, who is President and CEO of Colorado Access. Annie is also a board member of Early Milestones Colorado. Annie is a trusted and collaborative leader working within Medicaid landscape in Colorado, and she has held really many very important positions, including promoting community health, working with local schools, public health agencies, primary care providers, to develop holistic models of care and to address the social determinants of health. And I will say I've really enjoyed having her on the board, and her role in prompting us and pushing us to do more on health and really, really push on these inequity issues. Also thrilled to introduce Julissa Soto, who is a public health advocate and president of Latino Health Equity Consulting. We had lunch together last week, and it could have lasted into the late hours. There was so much to talk about, and so much passion, I think, between the two of us. And I'm just very, very grateful already to get to know her as part of this. For more than 20 years, Soto has dedicated her career to being a leading health advocate for the Latino immigrant equality community, focusing on equality, equity, and inclusion in Colorado throughout the nation. From working with teen parent programs and serving on the Colorado Vaccine Equity Task Force to promoting health equity at the American Diabetes Association, Soto has pioneered a wide range of programming designed to empower marginalized communities. So get ready, buckle your seatbelts. I think this is just going to be really exciting. I just want to say a little bit more about the format, and then we'll launch this. I want to remind participants that you can submit questions, written questions, through the Q&A component of this, and we'll be looking at those. And after we start a bit of a kickoff with the respondents, we will be introducing some of those questions for our respondents to answer. And I'm going to turn it over to Laura right now to present the findings.
Okay, I'm going to share my screen here. Okay, I think we're all set. I just want to thank everybody so much for joining us for this webinar today. I'm so happy that all of you are here to talk about these issues. And I'm going to be talking about and presenting some of the first analyses to come out of what Jennifer mentioned, Milestones Racial Equity Project, and focusing today specifically on equity issues among children in terms of health and healthcare. But some of you might know this is part of a broader effort at Milestones to study equity issues among young children, and not only in terms of their health and well-being, but also their early care and learning, and hopefully at some point within the child welfare system and their neighborhoods and family circumstances. And the rationale for this work was really came from the realization that there's not a lot of good data on young children in Colorado generally, and certainly not a comprehensive portrait of how children from different racial and ethnic backgrounds are doing. And I think this is a really important need within the state so that we can identify what children need additional supports and where. Okay. So before we jump into the findings, I want to say a little bit about what we mean by equity. So we went into this work hoping to find nothing, and that would mean that equity for children would mean that we didn't find any disparities by race, ethnicity, because all young children in Colorado have all the supports and resources they need to thrive in terms of their health and well-being. But that wasn't the case. And today what I'm going to be talking about are the differences we found between white and Latino children in terms of their health care, their health status, and their risk and protective factors. And the thing is, for kids this young, we really shouldn't see population level differences in their health. They're brand new, and while they're resilient, differences in their health and healthcare now can have long-term consequences in terms of their adult health, their longevity, and their overall success. And I think it's important to start this conversation by first defining what we mean by race and ethnicity. So when we're talking about race and ethnicity, we're talking about social and political categories, not biological ones. And just to be clear, racial and ethnic health disparities are not the result of biologically or genetically based differences, because biology and genetics simply do not neatly align with our racial and ethnic categories. So I'm borrowing from Dorothy Roberts here, as she writes in her book, Fatal Invention, that racial and ethnic groupings have very real consequences for people's health, wealth, social status, reputation, and opportunities in life. And with that, I'm going to jump into the findings from our analysis. The data we used for this analysis come from the National Survey of Children's Health. This is a survey that's been conducted by the Census Bureau every year since 2016 through 2021 in its current form. And every year they sample a couple thousand children from Colorado, give or take. And the sample is weighted to be representative of the child population in Colorado. And what that means is that they do not collect information from every single child across the state, but they use statistical methods to make the sample representative of that broader child population. Okay, so we set out to examine young children's health in Colorado by race and ethnicity. We limited our sample to children ages 0 to 8 who were surveyed between 2016 and 2021. And we combined those 6 years of data so that we would have enough kids by race ethnicity for this analysis. So parents and guardians reported their child's race and ethnicity the same way as they're reported in the census, where race and ethnicity are asked about separately. And here, white refers to non-Hispanic or non-Latino white, and Latino refers to children of all racial backgrounds. And we did that to maximize our sample size, but I do acknowledge that there are important circumstances that vary among Latino children across racial backgrounds. And I also just want to make a note about the terminology we're using. So we use the term Latino to refer to children whose parents and guardians indicated yes to the following survey question: is this child of Hispanic, Latino, or Spanish origin? And we considered what term to use to refer to children within this community. And on the one hand, as researchers, we were obligated to faithfully represent the data as it was collected. But we also want to acknowledge that the findings presented in this analysis come from a survey administered by the U.S. Census Bureau branch. And questions posed in this way result in institutional categories that might fail to align with the ways that communities define themselves. So on the other hand, we asked ourselves, how does the community in Colorado most commonly define itself? And the answer to this question, so we considered more gender inclusive alternatives, such as Latine or Latinx, and ultimately made the decision to use the term Latino because we thought it was the most widely recognized term among the community members. But I just want to point out and say that we welcome input from the community about how they want to be represented and the terminology they'd like used. Okay. So unfortunately, we were not able to examine children by race ethnicity beyond the two most populous groups of kids in Colorado, white and Latino children. And so roughly 12 to 13% of Colorado's children are identified by their parents and guardians as something other than white or Latino. And there were extremely limited numbers of these children in the National Survey of Children's Health data. So unfortunately, we can't draw conclusions about kids for whom we have only a handful of cases to represent. And for this reason, we were not able to include these children in the analysis, because doing so would potentially misrepresent them and their families. So specifically, the kids we can't see here with this data are African American children, Asian children, Native American and Indigenous children, and multiracial children. And these are not comprehensive categories. But just for context, that's about 4% of African American children in the state, 3% of Asian children, and 1% Native American or Indigenous children, and 4% multiracial children. So I want to say that Colorado needs to collect more data on these kids so that we can include them in future equity work. So the first set of findings that I'm going to talk about look at differences in terms of healthcare. So we know that routine preventative care is important for children, and we know how important it is for kids to have a primary care doctor or a healthcare or medical home. Because when children don't have these things, they miss out on services and they more frequently will end up in the emergency room. And what we found were that Latino children were less likely to have seen any health professional for any reason within the last year compared to white children ages 0 to 8 across the state. So here you're looking at the percentages of Colorado children ages 0 to 8 by race and ethnicity. You see that 86% of Latino children had not seen a health professional for any reason within the last year, compared to 93% of white children. We also found that Latino children were more likely to lack a healthcare home compared to white children. So there's a lot of literature about why it's so critical to have a personal doctor, a primary care physician, or a healthcare home. It's really beneficial for both children's and adults' health outcomes to have continuity of care, to build a trusting relationship with a health professional, because those things can make a meaningful difference in a variety of ways. So in terms of encouraging people to go to the doctor in the first place, and in terms of the quality and continuity of care they get when they're there. So you see here the percentages of Colorado children ages 0 to 8 who lacked a healthcare home. And what I want to draw your attention to are the green bars that represent Latino children. So you see that more Latino children relative to white children lacked a personal doctor or nurse, lacked a usual place to go for healthcare when they were sick, and lacked a usual place to go for healthcare that was preventative care. Perhaps as a result, we also found that Latino children were more likely to visit the emergency room compared to white children. And here you see on the screen the percentage of Colorado children ages 0 to 8 who visited the emergency room within the last year. That figure was 28% of Latino children, which was much higher than the 17% of white children. We were able to examine a few measures in terms of children's screening rates. So for context, the American Academy of Pediatrics recommends that developmental screening occur 3 times before a child turns 3 years old. And developmental surveillance and behavioral, social, and emotional screening are recommended at each checkup. And we know that regular screening and surveillance are important for early detection of developmental delays and access to early intervention services. And what we found was actually that screening rates were quite low among Colorado children ages 0 to 8 overall. We found that among children of all racial and ethnic backgrounds, 50% were screened for developmental, communication, or behavior problems according to their parents and guardians, and that 55% had their vision tested. That was ever tested for children 0 to 5 and tested within the last 2 years for children ages 6 to 8. Okay. We also found that doctors were less likely to ask parents and guardians of Latino children if they had concerns about their child's development, learning, or behavior. Here you're looking at the percentage of parents who were asked by their child's doctor about their concerns. It was 38% of parents and guardians of white children were asked, and 28% of parents and guardians of Latino children. Okay. Pause. We're going to present some of the findings regarding health insurance coverage and healthcare costs. And as most of you know, most children in the US are covered under some form of health insurance. And in Colorado, it's about 50% of children are covered under employer-based coverage, and more than a third are covered by Medicaid, CHIP Plus, or public health insurance of some form. And complete and continuous coverage is important for the overall health and well-being of children because it helps increase utilization of preventative care. So things can threaten that, like job instability, increased coverage costs, and also the removal of the continuous coverage mandate that had protected Coloradans served by Medicaid or CHIP Plus since the beginning of the pandemic from administrative disenrollments. Okay. So here you see the health insurance coverage type for Colorado children ages 0 to 8. And what we found is that most white children had employer-based coverage at 77% of white children ages 0 to 8. And most Latino children ages 0 to 8 at 57% were covered by Medicaid or Child Health Plan Plus. I want to point out that according to their parents and guardians, 93% of children overall had coverage that usually met their needs. And we did not find any differences between white and Latino children with regard to that, which is a positive story, I think, even though there are major differences in terms of coverage type at the population level. Okay, and here you're looking at healthcare spending within the last year for Colorado children ages 0 to 8. So what this is based on is parents and guardians were asked to estimate the amount of money they spent on that child's healthcare within the last year. And we found that compared to white children's families, Latino children's families spent less overall on their child's healthcare within the last year. So if you look down at the bottom, the green bar that represents Latino children, 42% of Latino children's families spent nothing on their child's healthcare within the last year, and that was lower at 16% for white children's families. And then if I draw your attention up to the top, it was 12% of Latino children's families spent more than $1,000 on their children's healthcare within the last year, but that figure was much higher for white children's families. So even though Latino children's families were spending less overall on their child's healthcare, they were struggling more to afford those healthcare costs. And what you see here are the percentage of families who reported difficulty paying that child's medical bills within the last 12 months. We see that almost 1/5 of Latino children's families were struggling to afford their kids' healthcare, and 12% of white children's families reported difficulty paying for those medical bills. We also looked at a few limited measures of children's physical and oral health status as reported by their parents and guardians. And I want to point out that although the National Survey of Children's Health collects a huge amount of detailed information on children's health outcomes, we were not able to report most of this due to the extremely small sample sizes within Colorado by race ethnicity. But here's what we did learn. Latino children were less likely to be in excellent or very good health according to their parents and guardians. So what this is based on is the National Survey of Children's Health asked parents and guardians to rate their child's overall health status in terms of the following options: excellent, very good, good, fair, or poor. And a similar measure exists for adults, in which adults rate their own health status on the same scale, and this is commonly referred to and widely studied as self-rated health. So you see here that fewer Latino children, even though it's the majority at 93%, were rated to be in excellent or very good health, as compared to 95% of white children ages 0 to 8 in Colorado. We also looked at these measures. Parents and guardians were asked about their children's oral health. So specifically, they responded to this question: how would you describe the condition of this child's teeth? And also, during the past 12 months, has this child had frequent or chronic difficulty with decayed teeth or cavities? And we found that compared to white children, Latino children were more likely to have poor oral health and chronic difficulties with cavities, according to their parents and guardians. So those numbers are 18% of Latino children were reportedly in poor oral health, compared to 12% of white children, and 11% of Latino children had chronic difficulties with cavities, compared to 7% of white children. Okay, so I'm a sociologist, and I can't do this presentation without talking at least a little bit about children's health risk and protective factors, because we know that what we refer to as the social determinants of health have a lot to do with fundamentally shaping children's health in a multitude of ways. And so I'm going to point out a couple of things here. We found that Latino children's families were more likely to experience frequent difficulty covering basic expenses like food and housing. Parents and guardians were asked specifically, since this child was born, how often has it been difficult to cover basic expenses like food and housing? And if you look down here at the bottom right, 28% of Latino children's families said they often had difficulty covering basic expenses. And that's a much higher figure than the 10% of white children's families. So in general, there's a lot more economic hardship among Latino children's families. However, we also found from the survey that white and Latino children benefit from similarly high levels of health promoting neighborhood amenities. So 92% of both white and Latino children have sidewalks or playground or walking paths in their neighborhood. 89% have playgrounds nearby, 63% have a recreation or a community center in their neighborhood, and 74% have a library or a bookmobile. Even though they have similar levels of neighborhood amenities, we did find that 1 in 10 parents and guardians of Latino children expressed concerns about the safety of their neighborhood for their kids. And that figure was lower among parents and guardians of white children at 4%, reporting that their neighborhoods were unsafe for children. So I think we learn a couple of things, and I'm not going to say a whole lot here from this research. First of all, that Latino children and families really need additional supports to achieve health and healthcare equity. And also that Colorado needs to collect better data on children by race, ethnicity, so that we can examine these kinds of equity issues. But I'm going to stop there and just thank everybody for listening to my presentation here and turn it back over to my executive director. And I look forward to hearing from our panelists and hearing from all of you in the Q&A.
So much, Laura. And a reminder that listeners can please submit their questions via the Q&A function. We already have some coming in. But we're going to start first with a few questions to kick things off and ask our 2 panelists. They'll each have around 10 minutes to respond to these 2 questions, and then we'll open it up more broadly. So the first 2 that I'd love to hear from you, and I'd love for you to share with the group here that's participating, is a lot of good and interesting data here. what else do you want folks to know about health equity that you know that isn't part of this these findings or this analysis? So that's the first one. And then the next one is name a couple policy ideas to address these issues and better meet the needs of children. They can be big, they can be small. Just get the ball rolling with some things we might be able to do. So first one is, what do you want folks to know additionally, and what are some things we might be able to do in the policy arena? And Lisa, I'll start with you first.
It has to be me, the first one. Here I go, my friends. What I want people to know, I first of all, I want to thank Early Milestones Colorado for shedding a light where inequities exist. None of this was surprising to me. To the contrary, when you were sharing the numbers, I was getting more and more upset. It touches my heart to see that we have to provide these numbers in order for community members to understand that we are being left behind in every single chronic condition: diabetes, cardiovascular disease, vaccines. We're 44th in the nation when it comes to MMR vaccines. We're also, everyone is vaccinated almost at 90%. We're under 40%, under 50%, I'm sorry. So what I would like people to understand is that if you observe from the presentation that some doctors were less likely to ask Latino parents about the questions that they would ask their white counterpartners, screen for developmental communication and behavioral problems. That's a problem right there. Why is it that we're not asking these questions to our children? Why is it that we're not asking these questions to our parents? Why is it that we're not taking the time to validate the cultures that we want to serve? Why is it that they want to get rid of us quicker than others? Because in my mind, it's like, if they're not asking these questions, then how is it that we're going to build a relationship between family and provider? That's where you're supposed to be building trust, talking to the community, talking to the parents. So I will love the community to understand and to know that this is happening, and it's happening every day. I organize vaccine clinics once a week, representing Colorado Access. And what I see is that most of these families don't have a provider and don't have a pediatrician. And when I ask if they have a pediatrician, some of those families ask me, what is a pediatrician and why do we need a pediatrician? So the problem is bigger than that, Jennifer, you know. So I would like everyone to know that. And about policies, I really feel that I make some notes in here. Half of Americans live in neighborhoods classified as childcare deserts with little to no access to childcare, right? We must promote bold policies, solutions to the childcare crisis that will expand access and affordability, bringing an inclusive and racially equitable vision to life. We need to work with those single moms. We need to work with childcare. We need to work with CCAP, better policies for CCAPs. Also, policymakers must recognize the need to help families who qualify to stay enrolled in Medicaid and to protect programs like Children Health Insurance, which offers coverage for those who might not be eligible for Medicaid. In the end, we all share a collective responsibility to safeguard the health of our Colorado children and the health of our public. Thank you very much.
So much. Annie, what are your thoughts?
Well, I have many, and I try to be succinct, but I probably will need some help with it. So Julissa, who is such a wonderful partner to Colorado Access, the organization that I represent, and just really quickly, for those of you who may be unfamiliar with Colorado Access, we serve as a regional accountable entity, which basically is a partner to the state of Colorado, specifically their Medicaid agency, healthcare policy and financing, and helping to coordinate care and assure access and quality for Coloradans on Medicaid. We also work in the Child Health Plan Plus program as well. So we are a public sector health plan. We work specifically to serve Medicaid families and those on Child Health Plan Plus as well. And again, Julissa is just a very dynamic, powerful partner in the spaces where we look to connect specifically with our Latino communities. So in terms of what else I would want people to know, I have a feeling that a lot of the folks who are drawn to this kind of presentation and webinar know a whole lot about these areas. So maybe I'll just be mostly building off of things that Laura mentioned in the conclusion slide there from the analysis. One is, I think it's important to zoom out of the healthcare disparities specifically to look at what's happening in our country. We've got significant wealth disparities that exist between families of different races and ethnicities, and that can be very strongly correlated to what you see in terms of health status and health outcomes. 2019, the Survey of Consumer Finances, one of those entities that looks at wealth differences and disparities, showed that the average white family has 5 times the wealth of the average Hispanic or Latino family. And just these are the kinds of things that give you a fuller picture and offers more insights in terms of the structural, institutional, and historical barriers that are really going to impact whether families are able to thrive. And that kind of examination really allows us to focus more on the kind of structures and processes that create and perpetuate these social and economic disparities, which are so important. There's sometimes a propensity in policy to look toward individual behaviors, is there financial literacy or health literacy or that kind of support that you can offer? But really, you do need to take a look at some of the, again, historical, structural changes, differences that have influenced where people are today. Another thing I would want to point out is that, and it's kind of a Captain Obvious thing, but just like Asians or African Americans, Latinos are not a monolith. And this is an extremely diverse population. We need more and better data. So that's what Laura said in one of her conclusion remarks there, to inform more impactful and meaningful policy solutions. I think a significant development in the past couple of years has been from the US Census Bureau. They have, as an offshoot, a survey of income and program participation. And in that demographic data, they now include what I believe they reference as detailed Hispanic origin variables. So they can see assets and liabilities data, again, looking at wealth gap for various Latino groups. So that's including looking specifically at Mexicans, Cubans, Puerto Ricans, Dominicans, Salvadorans, and Colombians. And that detailed data is really crucial to understand what differences exist across the kind of Hispanic origin groups. There are a lot of things that have already been looked at in terms of the length of time that you have in the US and how that impacts your ability to support health needs, to address and access what you need in terms of resources. Immigration citizenship status, initial socioeconomic status of migrant groups upon entry. Those are things that we know have an impact on what we can do on the policy side of things to support resource needs to address some of the disparities we see. Data specifically on health, in the Medicaid world, we have self-identified data when it comes to race, ethnicity, data that comes across eligibility files. And I don't know that that is something that we've worked on or tried to really get to a good place. And how is that data coming across? How is it used? How do we analyze that? And there's a rich amount of opportunity there. So not only in what's collected, but what we do with that data to inform care, to inform just how we resource across our work in healthcare. Last but not least, I would say a thing to know is that kids' health policy, what you're doing when you're focusing on kids generally, that needs a lot of attention and prioritization. For instance, in Medicaid, you have kids comprising over 40% of the Medicaid enrollee population. I think it's at 45% often. And it is less that, but in terms of serving that population, what it costs for their care, that's at around 20% of the total expenditures in the Medicaid program. This just means that, you know, when you're looking at prioritization in Medicaid policy, you're going to go into how you can help with the costs that are in Medicaid. So cost control often ends up being a focus in most healthcare programs. And if you have a population that isn't coming up high on the cost side, guess what? They don't get all the attention or the immediate attention. And that and other factors make it so that if you're out there looking at anything in terms of healthcare data, you need to ask questions about how the kids are represented and what we know about children. So it's so wonderful that Early Milestones is taking this specific look at how data looks for kids' health. You know, I would say another example specifically where my organization, Colorado Access, is engaged in partnering with the state. The state is prioritizing moving toward value in healthcare. That this actually has been a trend nationally for some time, to go from paying for just each service that's done in the clinic setting to really trying to pay for those things that are actually valuable and meaningful in terms of getting to the better outcomes in health that we want to see. As you do that, you're trying to then put certain kind of key performance indicators or measures that you are holding providers and others accountable for, be more focused on value and not volume. In doing that, the state has been very responsive in hearing out the advocates out there who've said, you know, the measures that you initially have come up with are very adult focused. Can we look at a separate track to be very specific into what it is that would be meaningful for the child population? And so HCPF is now working with others on creating that separate track and looking at how you move to value when you're talking about serving kids. Now I'm going to go to the policy side of things, and there's just so much. Again, I am sure that our audience has many ideas that I would love to hear when we get to the Q&A on their policy ideas and questions. I've already mentioned the data piece. Whatever we can do to get more meaningful data that it's actionable in this policy space of child health and how we address issues of equity is critical. I would also say that community health workers, also sometimes known as promotoras, how we really connect with people who are trying to access care, who need to be able to navigate the healthcare system, is of utmost importance. That's where, as Julissa talked about, the trust building happens. And community health workers and that model of connecting with people has been shown to make a real difference. When you can, first of all, if you're a healthcare worker that has some shared experience with the people that you're serving, that connection right there is so important. That's how you build trust in a very effective and efficient way. I've seen the model at work myself in many different settings at this point, and the state has just recently passed legislation that is going to lead to more support for how we reimburse for these services, because historically the community health workers are not clinical. They're typically, the goal is to recruit community health workers from the communities that are being served to then connect at sort of a different level to understand more about the social needs and the whole picture of health in a family or a community, and then to help with navigating the healthcare system from that place. So hopefully we'll see in the next 3 to 5 years a structure that allows for more community health workers to be part of care teams in healthcare. That's policy change that I'm very excited about. We also are lucky to be in a state where we have consistent coverage or access to coverage for kids for the most part. However, we know from looking at the news nationally right now that the unwinding of the public health emergency and that eligibility piece in Medicaid, that basically eligibility criteria being applied again and those processes being live again, is causing some people to lose their coverage. And some of it is administrative and not actually that they're not eligible. And those kinds of things bring up a need, I think, to have more continuous eligibility. That's the term that is used for when you basically have very low administrative barriers or requirements when it comes to renewing and staying on Medicaid, programs like Medicaid. There was a piece of legislation also that passed recently that will have continuous eligibility in place for 0 to 3-year-olds. So that's a good start. In other states, you will see there's movement to have continuous eligibility for all kids. So up to 18. And that's the direction that we need to go. Of course, coverage isn't everything, but it is such a critical starting place. Attached to that, I would say making sure that you have culturally responsive relevant care, culturally relevant care that builds, again, those trusting relationships. At Colorado Access, we were just so honored to work with providers who are Spanish speaking in the behavioral health provider network, who came to us and said, we would like to provide more support to the behavioral health providers out there who are looking to serve more Hispanic, Latino, Spanish speaking individuals on Medicaid. And they're the ones who kind of created the forums that we supported and kind of helped to bring together ways that lower that barrier that sometimes providers experience in trying to be in the Medicaid program or serve more Medicaid members. They are thinking through so many of the logistics and what's real for them on the provider side that could make a difference in how access plays out for Latino communities. So that kind of work and making sure that you're supporting providers and how they're becoming or on their journeys to become culturally responsive is also key. Just really quickly back to the coverage piece, I was also reminded of the work that's being done in the state to cover more undocumented individuals. This has been a gap for so long. The Affordable Care Act or Obamacare did not address anything for undocumented individuals. And we have two things. So within the last year, we have the Omni Salute, who's come online. That is an offshoot of our Connect for Health Colorado State Exchange, offering some coverage for undocumented individuals. And then we also have a bill that passed that will offer coverage for undocumented children and pregnant women, I think starting in 2026. Yes, 2026. So these are great things that are on their way, but the more that we can do in this space to make it stable, reliable, consistent coverage, the better. I'll stop there. Thank you.
So just like so jazzed up. So much of what you were mentioning or discussions Lisa and I had just last week, and we're getting some really great questions from those that have joined us for this webinar. I feel like we need some sort of summit so we can just like put it all on the table and have a day to really dig into these pieces of access and data and how to best serve our undocumented population, et cetera. So that's a sidebar, but I feel like we need to all get together in a more intentional way, and I think for a longer period of time to think about next steps. That being said, I want to get to some of the questions that have already been submitted through the Q&A piece on the webinar. And I'm going to start with this one, which is there a difference in the data when comparing Latino children that just arrived in Colorado versus Latino children that have been in Colorado for over a year or a period of time? versus those that were born here. And I'm gonna say that my guess is no, since we barely have the data that we have, we probably don't have that, although maybe I'm wrong. However, I would love to hear from both of you about what you know about the differences, because I think we can't just wait for the data. There are stories to tell, and there are experiences that we know that are probably thematic that could be really interesting to discuss. So anything you have to say about data or experiences comparing Latino children that just arrived versus those that have been here maybe a year versus those that are born here. Julissa, you want to kick it off?
You know, Jennifer, I think that like Annie was saying, income and inequality, she was talking about that. I said we can do much about that, but I think we must work with mistrust and lack of access. And I know that the newcomers, the new immigrants or immigrants such as like myself, right? I don't see a big difference between those children who were born in the USA and the newcomers. The newcomers come lost, don't understand what is prevention. They come with acute care culture. And I have seen that even with children that they were born here in United States. You know, the parents are still the same. The kids are US citizens, but the parents still those immigrants. Those immigrants, they have the culture of acute care. So it won't be a big difference between immigrant children, new arrivals, between the US citizen children who were born here, right? So, and I also feel that we will never have accurate data, because if we're looking at census and we're getting all these data from all those sources, you have to remember that a lot of us don't trust the system and we will never fill out the census form. So I don't think they would ever get 100% of that data, but we can get close, because I think Laura did a very, very good job. But yeah, between newcomers and the US citizen children, those are kids of immigrant parents. We still have the same mentality. We still have all of our traumas. We still have a lot of the traumas when we access care. Access care is almost impossible. We can have the greatest insurance, universal care, right? But if we cannot access care, for what is good to have Medicaid? For what is good to have any type of insurance, right? The problem in here has always been access, not access to health insurance, not access to Medicaid. Yeah, if we talked about Medicaid, you know, some of those forms are crazy and impossible to fill out. But you know, we can have every single children with insurance here in Colorado. We're still gonna face the same problem. We're still gonna face inequalities, you know, no equity for Latino children, and the data shows that.
Yeah, I might add in agreeing with Lisa that there's we know that there is a lot of data out there showing the trends are that the wealth gaps are deepening and widening, right? So for people who come to this country, how much wealth and opportunity they can access 1 year into being here in the US versus 5, the trends show there's not that much difference that's coming. The opportunities and what we need to be doing to support communities who have limited resources and limited access to opportunities, that isn't shifting enough. So you can imagine how that then is tied to what shows up in the health data. When you don't have resources, when you're not able to access opportunities, you're going to continue to see things kind of stay static.
Thank you. Okay, and this one I think has a lot to do with the prior question, and also I think probably these issues of trust. How might we rethink how language justice and language support services like translation and interpretation are funded to ensure health equity in healthcare settings? So what does that look like? How is it maybe working, and how is it not working with regards to language justice and language support services?
Go ahead, Annie, because I need to think about this one.
Well, I will tell you that the sort of the usual mechanisms that we have, which are through the telephone in a clinical setting, which are mostly through the telephone. You know, when we don't have enough resources for people to be in room or in the clinic space with us to do the language support services that we need. And the phone, those services, they serve some purpose. They meet some of the need, but it is just not conducive to building the kind of relationship you need in that space. And to have more bilingual providers, people on the care team who speak the native languages of more of the patients that they're seeing is really where you're going to get the best that you can get. And we need more of that. Rethinking that piece and how do we address the immense need out there is where I struggle too, Lisa. So I was just thinking, like, yeah. I don't know. There's a lot that we're trying to do in terms of workforce pipeline and how we diversify our workforce. That will take time, and I think it is taking hold, and there's more that we at Colorado Access are doing and others that we can see in the community are also doing to focus on diversifying the workforce. But I believe that that's where we need to focus. But certainly with technology and other kinds of innovative solutions to the language support services gap that we have, there should be more. I just don't have them right off the top of my head to mention.
Yeah, and I agree with you, Annie, because, you know, just the telephone is something cold. And then I don't know if you have been at the doctor's office when you have that translator over the little screen. They don't smile. They don't build a relationship with you. They barely answer what they need to answer. And that's it. And that's what they're hired for, right? Just to translate. But I certainly don't believe in translation. I believe in transcreation. I believe that we have to say what the English speakers are saying, but in the language of their heart, right? We are saying the same things, but transcreating. Please, everyone out there, stop translating. Start transcreating, validating the cultures of the people that we want to serve. Do not translate. And I feel also that the workforce, like you say, Annie, we need to hire more bilingual, bicultural people that are going to be at the front line, but also not only bilingual, but also with life experiences, so they can certainly connect at that level with the community, because some of us are very privileged. Some of us were way up here and the community is way down here. And so we need to have more providers that they understand the life experiences, because like I always say, we can empathize about their struggles, but never replicate their struggles.
We think about other work that Early Milestones has been involved in with regards to the child care and early learning workforce. And of course, many similar issues. You know, it goes beyond language, it goes into culture, but also into trust. Who is in your community that you trust, and who can play these roles, and how do we enable those individuals to be part of serving? Another place where I'd love to hear more. It's been a big struggle in childcare and early learning, but I'm sure that there are efforts underway in various sectors that we could all learn from. I'm going to move on, and actually, Laura, if you also please feel free to jump in on this one if you have some thoughts. The question is about, is there data available on why Latino kiddos were more likely to visit the ER compared to white kiddos? Is this also seen at the national level? So I'll just throw that one out to anyone that wants to answer.
I can jump in just quickly and say that no, we don't know from the National Survey of Children's Health why specifically kids are heading to the emergency room. They just don't ask. And with regard to the national level, I think that the trends differ depending on the children's ages, but I don't know the specific answer for kids 0 to 8.
And you know, Jennifer, I can tell you from my own life experience, when I first arrived to United States 24 years ago, I came straight to Colorado, and my friends would tell me to go to the emergency room to take my kids, for example, an ear infection, right? I will run to the emergency room 24/7 most of the time. And why we run to the emergency room? Because in there, they take care of us really fast. They don't ask us much questions. They take care of your kid super fast. And I feel that they discriminate a lot less than other providers, other safety net places, even though they're safety net places, they're supposed to be safe for us. But that's kind of like a culture that we have. When we first arrive, we talk to each other. And because, fear of deportation, fear of somebody having our information, we go to the emergency room and we feel that we stop by there one time and then we go to another emergency room, and that's our provider. We don't know. I didn't know the difference between ER, the emergency room, and having a provider. For me, a provider was seeing my kids for an ear infection. So when people would ask me, do you have a provider? I would say, yeah, he's at the emergency room, right? That's your provider. But for Americans was like, that's not your provider. You're going to the emergency room. Who's your provider? And for me, that was a very confusing question way back then, when they keep asking me about the provider, when I knew the provider is at the emergency room. So for a lot of us, the emergency room is our safety net. For a lot of us, the emergency room is our federal qualified center. And for a lot of us, the providers exist at the emergency room.
That's really interesting. There's so many places we could go with that. Annie, anything to add on this one?
No, I mean, I think that Julissa, in speaking from her own experience, is reflecting a lot of what's going on out there in the broader community. I guess I could add my own experience. I'm not in the Latino community, but in being a kid on Medicaid and a kid who didn't have insurance, and talking with my parents about what they went through, and they just said, well, we were at a place in life where those things were very difficult for us to coordinate. And I think we all can imagine what it's like when you have to think about the transportation and the time off work and all of those things that make it difficult, versus the ER is a place that you can easily, I mean, this is all relatively speaking, right, access. My parents said the same thing. We always knew there was the emergency room if we needed something, urgently. And that's the plan.
And Jennifer, for me, an ear infection way back then was an urgency, because when you see your kids with fever and suffering, it's all relevant in here, right? Somebody might tell me now, an ear infection is not an urgent matter, right? But way back then, when you barely know the system, when you don't know how to speak English, when you're undocumented, for me, every time I see them with fever, it was an urgency. So I would run to the emergency room. And like Annie was said, it's easy access. You don't have to call. You don't have to make an appointment. You don't have to call and then nobody speaks Spanish, or they treat you wrong because you have an accent. And then your appointments are 3-4 months way ahead. At the emergency room is easy access. They will see my son there and they will prescribe some medications and let's go, so it's also convenient for a lot of us, especially single parents.
So interesting, because it sort of flips it on its head to say, all right, what are those elements of an emergency room visitor experience that make it so accessible? And how do we then translate that into the more traditional, quote unquote, parts of the system, where, we might want more consistent providers, et cetera. It's like, what can we learn from that is working for families? Okay, we have another one here, and I did want to know, we have someone with their hand raised. I'm not sure how to take folks off mute, so if that person wanted to type in that question, if not, after this one, we'll work on trying to figure out how to take someone off mute and get that question answered. But the last one, and this one might be a little bit challenging, so I'm going to provide a little bit of context. The question is, what impacts do you think Colorado's universal pre-K program could have on youth health equity? And given that this is not necessarily your domain, either of your domains, I will say, you know, we're unveiling Colorado's pre-K program. It's rolling out as we speak. The number of families that signed their children up was far more than expected, which is really, really fantastic news for a universal pre-K program. I mean, great rates of enrollment that first year compared to other states. Quality standards have not been yet put into rule, but within the legislation, there is a mandate that somehow children that are in UPK are made aware of developmental screenings, whether those are at the program or in the community. So I would think that that would probably be the biggest tie, but if you have any additional thoughts on how something like UPK could impact health equity, would love to hear them.
Well, you know, I will just briefly comment that where families have access points to other parts of their community. So if school or where a child is enrolled in UPK becomes another place that they can receive some kind of support in how that child is developing and growing, that does make it so that there's more of the village that it gets built there, right, to support kids and families. So I think in terms of UPK coming through to allow for that to happen, allow for that stronger connection to broader community, to more resources, that does then help to make some connection to better health and resources there. It's not a direct line that you can immediately draw, but any place where you're able to think holistically about what's going on in a person or family's life that helps to kind of fill out a better range of supports, that's going to support better health. Not to mention, oh, sorry, I was going to just, one more thing, not to mention all of the evidence that has been piling for so many years around how important early childhood education is to the development overall of an individual's brain and what it means in terms of success over a lifetime. I mean, that sets you up differently for what you can access in terms of opportunities and growth. So that is an obvious one too that I should call out.
Laura, throw in to the mix on this one.
Was that at me? I couldn't hear exactly what.
Oh, I just said if there's anything else either of you want to throw into the mix on this question about UPK. If not, we've got plenty of other questions coming in. I will just answer one thing that has come up, and then I think we're going to take an individual off mute to ask their question directly. The question that I will answer is, will you have a full report to read regarding your findings? And the answer is yes. I believe when we send out the recordings, we'll be sending out the executive summary. Laura's nodding, so I'm not over promising. And then we'll have another report later. And there's some other interest here in risk and protective factors, key drivers of inequities in Colorado, recommended interventions. This is just the start. I don't think that all of this will be covered in this particular analysis and the sharings that we'll do as a written report, but I know that we would love to do more and hope to do more. So with that, Courtney, are you able to take Aaron off mute?
I am. Erin, you are able to unmute yourself if you'd like to. It looks like you have yourself muted, so the mute button is enabled, so you can go ahead and unmute yourself now.
I am so sorry. Do you guys hear me?
Yes.
Yes.
If I rose my hand, I am just in here taking fervent notes, so I don't have a question. Thank you. I don't know how I rose my hand. I apologize.
Oh, that's all right. We've got plenty of other questions, Erin, and if you do
Okay.
have, go ahead and submit it through the Q&A section of the Zoom, and I will move on to some other things that have come up. This is interesting. How do you think climate change and environmental inequities might impact the health of children and health disparities among children? So, any particular thoughts about climate change and environmental inequities and how those might show up and in Colorado or otherwise?
I don't want to be too general about things, but anytime we have something show up in society, whether it's a pandemic or climate change, that is going to impact everyone in some way, in terms of how we're navigating life and what we can access, who does it hit the hardest? It's the people who are already struggling. So, and we've seen so much already in terms of the disparities and disparate impacts that the pandemic has had on Brown and Black communities. I think we can see that playing out exactly with climate change as well. So what we can set up in terms of the structural and institutional differences we can make so that you don't have those impacts, again, hitting your most vulnerable, most resource lacking communities. That's what we need to do, and it's a real worry. You know, if people who are fairly comfortable in terms of their sort of socioeconomic status and don't struggle day to day are worried about what could happen to their homes and their livelihoods when it comes to different climate change impacts, you can only imagine how someone who is struggling day to day is going to be hit with you know, various challenges that come through climate change. It's I think it's one of those things on a kind of different topic altogether, but it is something like AI, artificial intelligence, where you just know it's coming and in big ways, and we don't have a good way of appreciating what the impacts are going to look like fully. And there's just so much work that we have to do to just do better in how we're making resources and opportunities available for everyone. These equity issues are going to play out in so many different ways in the climate change arena. And I wonder if there are people out there who have some thoughts on this. I guess the thing about panels is that I love hearing the questions, but it's like, I wonder what else people out there are thinking too, along with these questions.
Yeah, you know, and I am not the expert in climate change, you know, so I'm just gonna give my point of view. For example, if you're in poverty, you live in Commerce City, I feel that those children and those families will get more affected with climate changing, right? So Latino families, I feel that in those areas are hit the worst. But like I said to you guys, I'm not a climate change expert, but it kind of makes sense that it affects climate change would affect always the lower income communities, and it will hit them hard too.
Yeah, and Julissa, I bet that you'll be involved before long in more things that are connected to climate change. I mean, as the earth heats up and you have communities who don't have good access to air conditioning or, you know, ventilation, you know what communities are going to be suffering in need of more resources to kind of update their homes or be in a place where they can get through the heat that's coming. We're certainly working with organizations to look at those needs now.
Yes, and like you say, Annie, I wonder why people are asking these questions and how does that, what do they really think? And I will invite some of you guys to raise your hand and ask us that question and give us your point of view. Let us know exactly how the Latino community and also Latino children are being affected by climate change, because I know that some of you guys might be the expert on this topic. So I'll invite all of you guys to keep asking questions. Keep asking questions. People say that Annie and I are the experts, so we're gonna live by it.
As I'm thinking more about this question, I just have more that I can think of. We know rates of asthma are higher amongst those communities that live along the kind of I-75, I-70, and I-25 corridors. Well, who are the communities that live in those areas? And it is your predominantly brown and Black communities. So as air quality gets worse, as things with the fires, for instance, that are putting things in the air that make it so we can't go outside as much if we have some physical vulnerabilities, that just is going to impact child health and deepen those disparities that we see.
Did have someone with their hand up, and okay, Christos Cisneros, and please go ahead and take yourself off mute on your side.
Yeah, can you hear me?
Yes.
Yay! So yeah, Cristal Cisneros, I'm with Denver Preschool Program, and actually my entire dissertation was on environmental racism and its impact on kids. So there's a lot happening specifically in Denver County. I think the city is putting together some task force. Sorry, I'm out of breath. I ran up the stairs to get my book. But the city is doing a lot of task force specifically to talk about climate change and the way that it's termed urban jungle, but communities of color in Denver do not have a lot of tree canopy. And so not only when we see climate change happening, we see hotter cities. And then a lot of those schools you've been seeing in the news do not have access to air conditioning. So they have that on top of a lot of the same schools in these communities of color are within 500 feet of a major highway. So they also have emissions in CO2 runoff. So there's a lot of things that are impacting the physiological and biological development of the children, in part with just kind of the whole opportunity educational gap. But what I ran up here to get is, it's called A Terrible Thing to Waste, Environmental Racism and Its Assault on the American Child. And it's by Harriet Washington. And that book goes into the history of lead poisoning. So we see that in instances in Flint, Michigan, but it goes into climate change and environmental racism. And it just talks about the physical development of children and how it not only impacts them currently when they're in school, but also in utero. And a lot of families, specifically mothers, mothers of color, specifically Black mothers, also have a distrust with the medical system in itself. So incredible book, could talk all day about it, but I will leave it to Dr. Harriet Washington to go on.
Thank you, Cristal.
Thank you so much. I look forward to reading that book.
The total amount in the chat, that would be wonderful. Okay, we're going to end with one positive, a little bit more of a positive, which is, Julissa, I think this one in particular, you can help answer. What strategies are working currently to address barriers to childhood vaccinations for different groups? What's working? What's going well, especially with childhood vaccinations? And then after this one, then we'll do final comments.
What is working is that you have providers community health workers, promotoras like myself out there in the community, talking to the community. When you're organizing a vaccine clinic, make sure that you talk to Telemundo, Univision, the radio, and let them know where you're going to be. Also, make sure that you knock on people's doors. Go back to the 80s. I don't know why is it that now we're crazy about social media with a lot of the immigrants like this still that touch the one-on-one. So talk to the community, knock on people's doors, make sure that you get very much involved. If it's you're doing those vaccine clinics at the churches, that you're involved with the churches, and if it's a mercados, that you're involved there at the mercados and you're talking to people, but you're talking to people in a very cultural relevant way. Please do not come out with a lot of enough of brochures and flyers. If somebody will create more brochures and flyers, I will pull my hair like this, guys. Enough of brochures and flyers, because we are not hesitant, my friends. We need access. We need access to vaccines, access to care. So what really has worked with me and working with children at schools is that I touch the heart of their parents. I come to their parents and make it and assure them that their kids are going to be well taken care of. If they have some questions, which very rare they have questions for me, they just want to know where we're at and where is our next clinic, I will answer those questions. But I would always answer the question saying, I love your son or I love your daughter the same way that you do, mija, because I will not trust somebody with my kids that I don't know. So just assure them that you're there for them. Assure them that you're there to love them and not to question them. Please don't overwhelm them with scheduling appointments. No appointments, please. They don't want to give you their information, right? So we're building that trust. The status is a big issue. Immigration is a big thing in here. So make sure that when you organize your clinic, you say it's open to all, no appointments needed. Also, don't stress out so much about your vaccine card. If you lost the vaccine card, if you don't have the vaccine card, don't you worry about it, mija. We will give you a new vaccine card. Make it easy for the families. No appointments, no vaccine cards. Let them show up. And when they show up, you can look into CIS, the state system, to see which vaccines they need. So that's what has been working in Colorado, and partnering with Colorado Access and Colorado Community Health Alliance. We have vaccinated around 24,000 Latinos. We have been doing a lot of good work with Colorado Access too, and we have distributed 130,000 home COVID-19 test boxes, 80,000 masks, and we continue to do this work. We continue because this work is not going to go away this year or next year. This is going to be a culture. This is going to be a movement. And now CDPHE started with their mobile vans, and their mobile vans look super cool, guys. It looks like a kindergarten inside the van. So it's so the toys and the colors and the children love to see that. And just make sure that when you go to a vaccine clinic, you organize those vaccine clinics, you organize a vaccine party. A piñata is not going to cost you that much. I bring piñatas and put inside the piñata candy and home COVID-19 test boxes. So when children break the piñata, they get the home COVID-19 test boxes and they ask me, Mrs., what is this? And I said, that's for your mom, hijo. Go give that to your mom. So I raise some awareness with the mom, and I say the candy is for you, mi niño. So when we organize those clinics, I feel that those children are my kids, and I give them all the love in the world, and that will make a difference. Don't call them vaccine clinics, please. Call them vaccine parties. Who's going to want to go to a vaccine clinic to be vaccinated and paying? But if you're telling the children, mijo, come to my party, tell your mom to bring you to my party, believe me, those children are going to go and tell their mom, I want to go to her party. So that's why it has been working.
Yeah. Can I try to put an extra exclamation point on what Julissa just said? Because she has been a master at modeling, making things work so that we're getting more kids vaccinated. And so she's mentioned pieces of all of this, but I'll just say, I've been honored to work with Julissa. And first of all, you go where the families go. You meet them right where they are. So all of those barriers that could come from trying to arrange for transportation or childcare for your other kids or something, all of those things aren't there. If they're at church, they're at school, go where they are in the community. And then also make sure that you are building the connection with community. So you're there talking with them in their reality, and wherever they're starting or whatever they have in terms of questions or approaches to how they're trying to look at vaccines, Julissa is there to engage. And you just heard her say, just speaks so genuinely to how much she cares about the people that she's connecting with. Then she also is reaching out to community leaders who are the influencers, not in the social media way, but really in the community, who's listening to, who is the community listening to? Well, it would be the people at church. So going to the priests in the parishes. I mean, I was with Julissa when we went to the Bishop of Denver to talk about what it is that could be done from the church leadership to encourage more vaccines and vaccinations. Talking with the schools, going to the pharmacy school to then talk about how we can work from the healthcare system side to make it so that there's more people who are available to administer the vaccines, to be out there with Julissa and community leaders, looking at in a multifaceted way with that kind of a multifaceted plan on how you address the trust issues and the lack of access to resources, and what you need to build in the community so that there's some sense of infrastructure that's there to support the understanding and value around vaccinations is so important. And all of those things Julissa is addressed and more. I mean, we could go on. There's more to it. That she talked about public health as well, and getting involved in connecting up where public health is and where healthcare fits. That is such an important link to make as well. And we need more of it.
This is so good. Just a thing from both of you, which is give me just one word to describe your state of mind as a result of the data in this discussion. And Julissa, go first. One word.
You were cutting off a little bit, so you were cutting off, so I couldn't understand what you say. One word of what? My friend?
One word to describe how you feel about the data and this discussion.
You're asking a Latina for one word, my friend. I'm gonna try. I feel hopeful. This is the first time ever in 2 decades, and I'm not saying only one word, guys. This is my chance. In 2 decades, this is the first time I see data that has to do with my children. That has to do that you, Laura, are shedding a light where inequities exist. And thank you. Thank you. I just feel hopeful today.
Awesome. Annie.
Well, so Julissa totally stole my word, because as soon as you asked, the first thing that came to mind was hopeful. So I'm right there with her. But since she said that, maybe I'll pick determined as the next one. Just there is so much work to do, and so many of us that are determined to get to addressing these issues of equity. So I just thank you for creating this forum, for facilitating this conversation, and for everyone out there who took the time to listen in and participate.
Or I'll put you on the spot and ask you the same one word. And while you take yourself off mute, I just want to thank the entire team behind the webinar. We have Julio Alas, who has been assisting us, Courtney Thornton, Catherine, who's also been helping. It always takes a team, and I want to thank everyone who's been involved, including, and very, very importantly, our interpreting colleagues at the Community Language Cooperative. And Laura, one word from you.
Well, I would just, reiterate what Julissa and Annie said, definitely hopeful and determined, but also for me personally, this is just illuminating, maybe, because I can look at the numbers and analyze the data, but I think the real key here is having people like Julissa and having people like Annie and having the community here to have a discussion about what's going on, because just coming up with the numbers, like we have to do something about it, and it has to go somewhere. And so them being here and everyone being here today is really, really the key for me.
Wonderful. One word too, so I won't do that, but I will say we can totally do this. Like I am positive we could change these numbers. Like I know it. It takes everyone that is on this webinar and more, and it takes a lot of savvy and some support, but I think we can find it. So I hope really that this is the beginning, and that a year from now, we look back and we say we're on our way. 2 years from now, we are seeing that change, and we get the ball rolling, you know, starting today. So I'm just so pleased. Thank you, Laura, for doing the work. It's just the beginning. Again, the Zoom recording will be available in English and in Spanish, and we will send out that executive summary with it. Thank you to our panelists and those of you that gave us your time to listen in. Please send us any additional comments, thoughts, ideas, and let's just do this, okay?
Thank you.
All right.
Thank you.
Thanks, everyone. Have a good afternoon. Bye-bye.
Adios.
Take care, everyone.